Dr. Thomas, thank you so much for your, first of all, your first part of the presentation. And thank you for introducing me. Thank you for speaking about the history of my specialty with Dr. Sims. So Dr. Sims, if he were alive today, he would have been called urogynecologist. And urogynecology has certainly have gone tremendous ways forward since those days. We've developed into a new field, which is a now not just gynecology name, as you can see, gynecologic surgery. It is a urogynecology, which is the specialty that specifically focuses on surgeries that are related to bladder in women. And fistulas or vesicovaginal fistulas is the condition that I frequently take care of today. Fortunately, it's not as often as it used to be. And fistulas are actually one of the oldest in history pelvic floor disorders. It's even been documented in wives of Egyptian pharaohs, 5000 BC, and it's been documented in the mummies. So it is one of the oldest pelvic floor disorders known to human history. Not only we've delineated this specialty as a part of gynecologic surgery, but we also now emphasize that urogynecology is not only about surgery, but a lot of things that what you do is medicine. So that's how it evolved further, and it received a new terminology. In 2013, it became a board certified specialty, female pelvic medicine and reconstructive surgery. So we treat our women with medicine first, and only if they do not do well with medicines, then we resort to reconstructive surgeries. And I'm very excited to be here and talk on my personal perspective of where we are today, so it doesn't hold us, that the past doesn't hold us back, and we learn from the past, and we move women's health and women's health research. You can't move women's health research without pushing forward women's health research. So I'm really very grateful to GHUCCTS community and the GHUCCTS leadership for supporting this event, and also supporting specifically my research that I do for women. Next slide. So in the theme, to continue with Dr. Thomas, we're going to learn from history, and I'm going to just show you a few examples of how we safely perform, how we safely move women's health forward. And the punchline, the theme of the talk is really those who don't know history are destined to repeat the mistakes, repeat it. Next slide. So we're going to focus on women's health, and as you can imagine, women's health is very basic. It's any particular treatment or diagnosis is a branch of medicine that specifically focuses on well-being of specifically women. This is what I do for a living every day, and I love doing it. And I'm doing this since 1996, when I graduated from my medical school. Next slide, please. So part of women's health, and women's health evolved quite significantly. So now we have female pelvic medicine, which is my branch, or urogynecology. We also have gynecologic oncology. These are the doctors who specifically work with women with cancer. We have maternal fetal medicine. These are the doctors who take care of women with high-risk pregnancies. We have generalists who just do annuals and pap smears. And then we have also doctors who take care of women who are not able to get pregnant, or infertility doctors. Moving and narrowing down specifically to my specialty, These are the most common pelvic floor disorders, and vesicovaginal fistulas and rectovaginal fistulas would be not the most common, fortunately, condition. But most common pelvic floor disorder is urinary incontinence, bowel dysfunction or fecal incontinence, any problems with the bladder where you're not able to urinate, pelvic pain, any problems with sex, and I frequently also see women with urinary tract infections. Next slide. So when I see women with pelvic floor disorders, women frequently come to me without knowing much about it, and frequently I get asked the question, how common pelvic floor disorders? And the pelvic floor disorders are extremely common, as you can see on this slide. And the first two bars on the left are just showing how common pelvic, in the blue, these are the numbers. So we estimate that about 25 million women in America have at least one pelvic floor disorder. And this number, if you can see from the blue bar to the red bar, you can see that the number is expected to increase significantly by 250. And it's mostly because the population in the world, and specifically in the United States, is expected to continue to age, and the population 65 and older is expanding more rapidly compared to younger population bracket, and pelvic floor disorders tend to develop more as women get older. So the number of women with pelvic floor disorders will continue to increase. So, and one of the most common pelvic floor disorders is urinary incontinence, followed by problems holding stool, very embarrassing condition, could absolutely ruin your quality of life. And then prolapse, which is not the topic of the day, but it's also something very commonly that we even perform surgeries for. Next slide. Pelvic floor disorders are unique in terms of many women have it, 1 in 3, but not a lot of women talk about this because it's really a private issue. Women are not willing to speak about this condition or conditions just freely, even with their friends or their family members. So this example, and I'm not a big fan of Dr. Oz, so I'm not supporting Dr. Oz, but he did speak about one of pelvic floor disorders, and he did acknowledge in his talk that this is the slide, suffering in silence. And frequently that is the case, that women come to me, to my clinic, and they were not able to speak with even their previous physicians. And they're the first, they're talking to me about their condition for the first time. And I have no idea what Dr. Oz has in these little glass jars. But next slide, please. And this is again to just emphasize that pelvic floor disorders are not frequently reported and underreported. And this is specifically the study about urinary incontinence, where 62% of people, and it's actually not specifically to women, just in general, men and women never really discussed this condition with their providers. Now, why is this usually underreported? So frequently, girlfriends would frequently talk about, their treatment for breast cancer or how they had a heart attack, and et cetera, et cetera. But women will not share that they need to wear pads. It's just embarrassing. They're afraid to talk about this because they're afraid of social stigma or consequences. A lot of women don't believe that anything could be done, or we had some surgeries that potentially not had the best outcomes. So a lot of women are afraid to even have treatment or surgery because they're concerned that this could make things worse. And there are some women who believe that urinary incontinence, or not able to hold your bladder, is just part of being getting older and aging, and thus they don't do anything about it. But what happens as women get older and they become more socially isolated because now they don't want to go outside. So they become more and more confined to their whatever the environment is, which eventually leads to worse depression and worse cognitive function. And eventually, this can actually even lead to nursing home admission. And urinary incontinence has been cited as one of the leading causes for nursing home placement, which can be quite devastating for family and for a woman patient. Next slide, please. So speaking again about pelvic floor disorders or urinary incontinence, it's not specifically limited to older women, although the prevalence of pelvic floor disorders and urinary incontinence does run more frequently in older population. But roughly, I would say that any audience that I speak, I would say, whether it's young or old, I can say 25–30% of women at least experienced some episode of some pelvic floor disorder in their lifetime. Next slide, please. So this is just an example of another condition. It's a urinary incontinence type, which is most commonly encountered in middle-aged women. You can see women exercising here, but I see a lot of women in my clinic that are not able to exercise because they have leakages with coughing, laughing, and sneezing. And we can do a lot of things. We actually have great surgery for this as well. But we do observation. I have a special, I call it bladder boot camp clinic or pelvic floor therapy clinic where women get one-to-one physical exercises practicing. Pessaries, which is a little rubber circle that can also support the bladder, and eventually surgery. And women actually do really well with some of our surgical treatments. Next slide, please. So we spoke a little bit about urogynecology, about the history of urogynecology, especially with experiences that Dr. Thomas described with care that was provided by Dr. Sims, who is considered to be still a father of gynecology. And when I was a medical student, he is still in every textbook of surgical gynecology. But this is not what we do today. And women's health research is very different from those days. And I really love this circle. I would put a woman instead of star in the middle of it, because it's really the circle where we ask a question that is clinical. So if I have a patient that came to me to discuss her condition and whether it's to prevent, diagnose, or treat the condition, if she poses a question that I'm not able to answer in a straightforward fashion to her, that becomes a research question. And then we develop the research question, and if we're lucky enough to complete the research and answer the question, then this goes into the next stage, which is evidence summary. We learn from the research. And then once we obtain enough evidence about this particular question, and it's usually not just one study, it depends how great study is, but usually it's at least several studies, then this summary becomes with becomes part of the guidelines, which is now the next step is translation into guidelines. And then we also study and we do practice integration of this knowledge. And then we evaluate whether what we thought we studied is correct and truthful. So, and that's your stage 5, and that's a full circle. And that's what we do in our clinic. And it's just fantastic that I have this opportunity to communicate with women who come up with questions, and I frequently don't know the answer. And then I start the engine, and we develop this into a research. And this is how we move forward women's health into, to provide better care to our women. Next slide, please. So, and this is a specific study that we are currently conducting at Howard. It is suspended because of the COVID. I made a decision to suspend the study because my age group population of women is 65 and older. So I was very concerned, and I actually suspended the study 2 weeks before university shut down research operations, and actually before it became really bad. We are looking into resuming currently the protocol with a modified schedule with a lot of Zoom exercises. But the study originated exactly in the same circle from previous slide, where I had a patient who inspired me to dedicate my academic career to helping women with urinary incontinence. And if you remember from previous slide, urinary incontinence is the most common pelvic floor disorder, and currently we estimate that 18 million women suffer from urinary incontinence. So as I say, when I'm in the clinic, I help one patient, one woman at a time. When I'm doing this research, and if it's helpful, then this will go into guidelines, and eventually this will be helping 1 million women at a time. Next slide, please. Belmont report, which actually was developed here not far away from Baltimore, Maryland. So the 3 golden rules of research: respect for persons, beneficence, which is do not do harm, and fairness or justice. These are all principles that all research that is currently performed in the United States and actually around the world follows these 3 golden rules. And this is, of course, something that we do here at Howard as well. And it's not only specific to women's health, but we certainly guard this in women's health very seriously in a very strict fashion. All women undergo informed consent. We specifically delineate all potential benefits and risks to the patient. And we always care. We want to make sure that the treatment that we provide is fair and just to the participant. Next slide. So again, learning from previous lessons from history, we developed regulations, and we followed the federal regulations, which are focused on protecting our participants, making sure we're informing participants, and we obviously do research review before we even start, just to make sure that and I don't do this. I come up with a research question, and somebody else reviews this to make sure that this is safe and fair for our patients. Next slide, please. I'm sorry, I think my computer is about to shut down, so let me just make sure I connect to the energy source. Okay. So just as an example, every study, every research trial that is conducted at Howard undergoes a specific board review. It's called Institutional Review Board, and it's done multiple cycles through the year. We provide the reports of the progress. The study usually is approved. Well, you have to submit the continuation every year. So there's a lot of paperwork that is that goes into place, and it's all really to follow these 3 rules that we discussed about, which is informed consent, do not harm, and be just to all participants. So it's a very rigorous process. Next slide, please. So in summary, as we started with our theme, that those who don't know the history are destined to repeat the mistakes, but we also would like to add that those who don't know the history and who don't implement the rules to prevent it from happening again are likely to repeat the history. So we definitely implemented a lot of rules on a federal level and university level to make sure that women's health is moved forward safely. Next slide, please. And this is just an example, and I really, really miss the time, pre-COVID time. As you can see, no one's wearing masks and everyone is super, super happy and enthusiastic. This is part of my team for this exercise study that we're doing for older women with urinary incontinence. And I'm indebted to all my team members. I wouldn't be able to do this by myself, and especially I won't be able to do this without women who come and volunteer their time, and it's quite rigorous to participate in the research. Next slide.